Hi friends, welcome back to next level ophthalmology. Today will be our last class in this chapter. We'll be dealing with investigations, myopathies and headache. So investigations in neuroophthalmology are many, but today we'll be talking only about CT scan and MRI. So we are mainly concerned about neuroimaging today. So what are the differences between the CT scan and an MRI? CT scan is a more sophisticated form of an X-ray in which you have multiple tubes of X-ray going around the patient and multiple receptors which catch the signals from the body and reconstruct it in a 2D fashion. So you can have coronal and axial views, and here the bony lesions are very well visualized and you can detect calcifications better. It's just like an X-ray, just that you can have a better identification of structures. So the primary indications include orbital inflammation, any trauma when you're suspecting a foreign body, presence of a tumor, to understand thyroid ophthalmopathy, and to pick up disc drusen which is not visible on fundoscopy. What about MRI? MRI is mainly based on magnetic resonance imaging. It's better to pick up or to understand soft tissues. So here you get three views: coronal, axial and sagittal. Some techniques which help in better delineation are fat separation techniques, especially helpful in understanding the optic nerve diseases because it's surrounded by orbital fat. So in these techniques the orbital fat signals are reduced and the lesions are better understood. So the main indications are for orbital tumors, optic nerve gliomas, orbital apex and paracellular lesions. Let's take a question here. Which of the following is true about MRI and ocular tissues? So we see a lot of T1 and T2 in the questions here. So what is T1, what is T2? So the basic principle of MRI is there are protons which are hydrogen atoms which are present in various tissues in the body. Alright, so when you apply a very strong magnetic field, these protons get aligned in a particular direction with respect to the magnetic field. So when a short pulse of radio frequency is given, there is a change in the orientation of these protons leading to the change in their axis. So once the radio frequency is withdrawn, there will be a shift of these protons from a higher energy level to a lower energy level. So around 67% of these protons that you see when they are getting back to their original energy level, the time required for this is called T1, whereas the rest 37% of the ions or the protons that need to get relaxed from a higher to a lower energy state, these are termed as the T2 weighted images. So it's mainly T1 means the time elapsed for most of the ions or the protons to return back to their original status. So this is usually a longitudinal or a z-axis kind of a shift, whereas the T2 is more of a horizontal or a xy dimensional shift. So what happens in this? In T2, remember that it's very important for the surrounding tissues to have a lot of protons. When there are a lot of protons in the surrounding tissue, there is a bright signal. Whereas T1 is mainly dependent on your magnetic field. So T1 is mainly required for understanding the anatomy, the normal anatomy, whereas T2 is to understand the various pathologies. So what happens in the options here? Let's go ahead and see. Vitreous appears hypo-intense in T1 weighted images. This is right. Why? Anything that contains more water is hypo-intense in T1, whereas in T2 it becomes hyper-intense. So these are the words which we use for CT and MRI. When we say intense, we are talking about MRI, and when we say dense, we're talking about CT. Hypodensity, hyperdensity in CT scan, whereas hypointensity and hyperintensity in MRI. What about echo? When we use the word echo, we are talking about a B-scan ultrasound. So hypoechogenicity and hyperechogenicity. Okay, so the first option is right. Let's have a look at the other options. Bone appears hyperintense in T2 weighted images. This is wrong, because anything that is solid will always appear dark in MRI. Bone, calcification and water all are black. So you cannot, it is not a good investigation to identify bony lesions. So this is wrong. Calcification appears hyperintense, again wrong. So calcification also appears black in MRI, so it's of no use. Fat appears hypointense in T1 weighted images. This is also wrong, because fat appears very bright in T1 weighted images. So the answer here is vitreous appears hypointense in T1 and it appears hyperintense in T2 weighted images. So let's revise. T1 CSF vitreous appears hypointense in T1. Fat, blood, contrast agents and melanin appear hyperintense. So I want you to remember this contrast here, because after giving a contrast, that is gadolinium, you will have better delineation of tissues. And which frames do you have to look? You have to look in the T1 weighted images. Whereas in T2 weighted images, blood vessels appear hypointense and CSF, vitreous and any inflammatory material will appear hyperintense. So this is a table for you to understand. I've taken this from Yanoff and Duker. So air, bone and dense calcification, okay, all three you cannot differentiate. They all look dark in both T1 and T2 weighted images. Whereas proteins, high protein containing substances like contrast, melanin, they appear very bright to begin with and they become hypointense during T2. Whereas fat is bright in T1 signal and dark in T2. Anything that contains a lot of water will be dark in T1 and bright in T2. Viscous protein, fibrosis, durameter, ligaments appear dark in both T1 and T2. So what happens to the muscles and the nerves? They appear light grey in T1 and they become darker, in the sense they become more hypo-intense in T2 weighted images. The grey matter appears, grey and white matter, how do you remember this? The grey and white appear grey and white in T1, so it looks normal in first. So T1, remember T1 is more anatomical, the anatomy looks as it is, whereas in T2 it is reversed. Okay, the grey appears brighter and the white matter appears duller, so the white matter becomes more hypo. So there are a few things in MRI, so whenever you come across these words, you should know what they mean. So DWI is diffusion weighted imaging. It's very useful in identifying cytotoxic edema, demyelinating plaques, inflammation and early infarction. FLAIR is fluid attenuated inversion recovery. It is helpful in suppressing the signals from CSF. So your white matter plaques are well delineated and especially helpful when you are thinking of MS. So if a patient has optic neuritis and you want to pick up the white matter plaques on neuroimaging, you have to look for a FLAIR. You have to order a FLAIR sequence. What is STIR? Short tau inversion recovery. This delineates optic nerve, especially the orbital one, by suppression of the surrounding fat. Then what is contrast enhancement? Gadolinium is the contrast material and it is a very safe material. It's only contraindicated when there are some blood disorders like sickle cell anemia. This helps in better delineation of inflammation, so better seen in T1 images like we just discussed. So next question, all of the following are preferred parameters for an optic nerve study on MRI except T2 fat saturated sequences. Yes, you need fat saturated sequences in T2. Slice width of 3 to 4 mm, you need a thinner width. Yes. Interslice gap of 1 to 2 mm. Yes. CT scan should precede an MRI. No, you do not need CT scan. You don't get a good information about the optic nerve status by CT scan and it is not correct. So this is the right answer here. Okay. Terson syndrome may include all of the following except hyphema, vitreous hemorrhage, preretinal hemorrhage and subarachnoid hemorrhage. So what is Terson syndrome? Terson syndrome is a combination of intracranial hemorrhage, associated with a intraocular hemorrhage. So there is hemorrhage in the brain as well as the eye. So all the following options that I have given you here are examples of intraocular. So the only exception here for inclusion in Terson syndrome would be hyphema. So why do we exclude hyphema? Because the proposed mechanism for Terson syndrome is raised in ICT due to the intracranial hemorrhage, which translates along the optic nerve, and then there is a rupture of the vessels within the optic nerve in the central retinal artery, which can give rise to a vitreous hemorrhage or a preretinal hemorrhage, or this had to be subhyaloid hemorrhage, okay, or a subhyaloid hemorrhage. So all three can occur along with the subarachnoid intracranial hemorrhage. So hyphema never occurs as a part of Terson syndrome. So let's move on to oculomyopathies. The most common one is myasthenia gravis. When only the eye is involved, we call it as ocular myasthenia. When no other tissues in the body have myasthenia gravis, we call it ocular myasthenia. It is a potentially life-threatening autoimmune condition characterized by formation of autoantibodies against acetylcholine receptors of the NMJ of the skeletal. So we are mainly worried about the nicotinic receptors which are present in the skeletal muscles. So in eye, which is the skeletal muscle, one is the lid muscles, LPS, and then others are extraocular muscles like superior rectus, inferior rectus, and others. Okay, so what are the manifestations of ocular myasthenia? There can be ptosis because of the involvement of the lid muscles, and there can be diplopia due to paralysis of some of the muscles. It's more common in females, but it can occur in male, and it can occur, of course, in the pediatric age group as well. Okay. So the most pathognomonic feature is there is muscle fatigue and weakness, which typically is more in the end of the day and improves with rest. There is a variability. So whatever these manifestations of MG are, they have a variability, and the patient is very well aware of these. Okay, shall we take a next question now? A 44-year-old woman presents with unilateral ptosis that gets worse in the evening. All of the following tests lead to the after image except hydrophonium test, eye SPAC test, eyelid fatigability test, and following administration of neostigmine. So here is a unique example for a patient with presence with unilateral ptosis alone. These patients need not always have bilateral ptosis just because it's a systemic disease. Okay, so the important clue for myasthenia gravis is that gets worse in the evening. So variable ptosis and variable diplopia both are characteristics of myasthenia gravis. So the options here are, what is hydrophonium? Hydrophonium is a short acting anticholinesterase. So after giving 2 mg of intravenous hydrophonium, we wait for some time to look for any allergic reaction. It's also given with atropine just to avoid muscarinic symptoms. Then following this, we give 8 mg of loading dose and look for improvement in ptosis. So it can be, if there is ptosis, we record the ptosis in the form of images like this, or you can even perform a field analysis which shows a superior defect in a ptotic eye, and the superior defect in the field is better after the hydrophonium is given. Or you can even do a diplopia charting or a Hess screen charting for documenting the diplopia. So this is hydrophonium. Eye SPAC test. When you place eyes on the lids for at least 2 minutes, there is an improvement in ptosis. So before eye SPAC, you can have ptosis which improves afterwards. So eye SPAC is also possible. Eyelid fatigability. So what happens is, when you ask the patient to look up for at least 1 minute, slowly there is worsening of ptosis and the lid starts drooping down. So here the lid has improved, the ptosis has improved. So this might be the right answer because you are looking for something except here. Following administration of neostigmine, yes, neostigmine also helps in improving the ptosis. So the right answer here is C. So there are various tests that we do in myasthenia gravis. So let's understand each of them. So in the eyelids, these are the first to be affected, as eyelid muscles are fast twitch muscles, and usually there can be unilateral or bilateral ptosis. Asymmetric and variable are two important words I want you to remember with respect to myasthenia gravis. Then eyelid fatigability test is increase in ptosis after prolonged upgaze. This is another test that helps in picking up myasthenia, that is the Cogan's lid twitch. Here the patient is instructed to look down continuously for 15 seconds and then asked to fixate at a point in primary gaze. So when there is an upshoot, the lid shoots up briefly and then comes back to its original position. So this is known as a Cogan's lid twitch. Then there is a positive eyes test, which shows improvement of ptosis after placing eyes on the lid for 2 minutes. Next, we have the extraocular movements, where we can have diplopia that can be horizontal or vertical, and usually there is no proper pattern that this diplopia follows. Okay, so whenever you cannot identify a proper pattern, and then you order a neuroimaging and it is normal, then you should always think about myasthenia gravis, even if there are no systemic features, because this can be just ocular myasthenia, and many a time systemic myasthenia gravis can present only with ocular symptoms, so does not fit into a recognizable pattern. I want you to remember this. Okay, what about generalized? You can have proximal and distal muscle weakness, presence of absence of deep tendon reflexes, and rather rarely you can have respiratory distress. So hydrophonium test, how is it performed? It's a short acting anticholinesterase agent that increases the availability of acetylcholine at the neuromuscular junction. 2 mg is given after 0.3 mg atropine, which is followed by 8 gram of hydrophonium. The subjective improvement in ptosis and diplopia is recorded. So what are the treatment options for myasthenia gravis? Neostigmine, pyridostigmine, plasmapheresis, intravenous immunoglobulins, systemic steroids, and thymectomy. So now let's move on to CPEO, or chronic progressive external ophthalmoplegia. There are two variants. The first is oculopharyngeal dystrophy, which is characterized by intermediate degree of weakness of the pharyngeal muscles, temporalis wasting associated with ophthalmoplegia. The Kearns-Sayre syndrome is characterized by a severe ophthalmoplegia associated with severe ptosis and retinitis pigmentosa. As the ophthalmoplegia here is symmetrical, you would not have any diplopia. Let's move on to headaches. Headaches, also known as cephalalgia, constitute a very important problem in the society, causing a lot of morbidity. So you can have primary or secondary headaches. Primary headaches are the ones with no underlying cause, and secondary headaches usually have a ophthalmic underlying cause. So these are the ophthalmic causes for headache which you will have to rule out in any case of headache. You might even have sinusitis or any dental pathologies that are referred to as a headache. So let's understand the more common primary headaches, migraine and cluster headache. Migraine is a common headache disorder of unknown etiology, and it's usually characterized by paroxysmal, extremely severe hemicranial pain. So here the catching word is hemicranium. So there is usually one-sided headache. So that is why this hemicrania, it was known as hemicrania, from which the word migraine has been derived. And it's usually associated with specific triggers. Okay, the common triggers are coffee, chocolate, lack of sleep, menstruation, too much stress. So all these are particular smell. Okay, very strong perfumes can also trigger migraine in people. There is usually a very strong family history, and it improves with rest. Okay, so the other features associated with migraine are photophobia and phonophobia. In the sense, they usually like to lock themselves in a quiet, dark room, and they do not tolerate any loud sound. Okay. So etiology is not very clear, but we think it is vascular in origin. We think it's arising from the brainstem, followed by vasoconstriction or vasodilatation of the intracranial and extracranial vessels. Okay. So a 23-year-old woman presents with one-sided headache which begins during her menstrual period and is associated with severe nausea and vomiting. So it's a one-sided headache, it's a hemicrania. Menstrual period is a trigger and associated with nausea and vomiting, which is very classical of a migraine. It's associated with photophobia and the lady prefers to be in a dark quiet room. So most probably we are dealing with migraine here. What is the false thing about this? Pick the wrong statement here. It's usually associated with a positive family history. True. Chocolates and coffee can be usual triggers. True. Cannot be relieved by medication. No, you can. Okay. And may be associated with third nerve palsy. Yes. So this entity is known as ophthalmoplegic migraine, which is a very rare cause of a very rare variant of migraine. So ophthalmoplegic migraine. So there are many drugs that can be used to relieve the attack of migraine. So the next question, a 56-year-old woman with hypertension and a past history of migraine. So on oral sumatriptan SOS presents with increase in severity of headache since last 1 month. Okay, it is associated with diplopia and drooping of the eyelid that recovers after the headache subsides. So here we have a patient who's been having migraine. Now she has developed some systemic comorbidities. Okay, and now there is a change in pattern of migraine. So this change in pattern or severity of migraine is always a red flag. Okay, whenever the headache pattern is changing, you have to think something else might be the problem here. So what is true? Let's find the true statement here. The severity of migraine increases with age, so double the dose of medications. This is not true. Okay, then change the medications and include propranolol. Again, not sensible. Only treat hypertension. No. See, there is some amount of neurological symptoms here. They are saying there is drooping of eyelid and diplopia. Probably we are dealing with a third nerve palsy as well. So there is a change in pattern, so which was a common classic migraine, now it's changing into an ophthalmoplegic migraine. So the answer here would be better investigate the lady with a neuroimaging. So the answer here is D. So these are the red flags in migraine: change in the pattern, change in the number of episodes, increase in the severity of migraine, new symptoms, new neurological features that are appearing during the headache. So how do we classify migraine? Common migraine or migraine without aura is usually characterized by headache, nausea and vomiting without any aura. Classical migraine has an aura. The aura is usually a visual aura, and you usually see something known as a fortification spectra. You see bright lights in the form of a fort which go on closing towards the visual field. It's known as fortification spectra. You can even have auditory and olfactory aura. Acephalic migraine or migraine without headache is classical migraine features without headache. Like you have the nausea, vomiting, photophobia, phonophobia, just the headache is not there. It's as disabling as migraine. You may have focal neurological disturbances and usually more commonly seen in the 40 to 70 years of age. Ophthalmoplegic migraine is more common in the pediatric age group, very rare, and usually third muscle is the one which is commonly involved. Retinal migraine, it's associated with visual loss with a normal looking retina. And basilar artery migraine is characterized by posterior symptoms like blurring of vision, diplopia, vertigo, gait disturbances, visual hallucinations and dysarthria. So a 38-year-old man presents with headache with features suggestive of migraine. He gets not more than one attack per month. So the number of attacks per month is less. Okay, just one. He has been taking on and off naproxen but not finding relief. Which drug among these is not suitable for this patient? So we should know that treatment of migraine is a stepwise approach. The first step would be to rule out any other secondary causes of headache. Even if you know it is migraine from the history, okay, headache classification and diagnosis is mainly history driven. Okay, you do not get any clinical features of this, so you have to take a thorough history. Even after doing a thorough history, you have to rule out secondary causes of headache like uncorrected phorias, uncorrected refractive errors, presbyopia, to make sure there is no ophthalmic cause. After doing that, there are a few drugs which you can think of. The first would be a plain NSAID along with an antiemetic starting from paracetamol or naproxen. So here they are saying that naproxen is not helping. So the other drugs which can be useful are ergot alkaloids. We know that they can be used. Sumatriptan, yes. Intranasal butorphanol, yes. Oral propranolol. So this is used as a prophylactic drug and not for a attack. So oral propranolol is indicated when there are more than 2 attacks per month. So prophylaxis is indicated when there are more than 2 attacks per month or associated with a neurological deficit. So the answer here is D. So these are the drugs of choice that you can be used in any acute attack of migraine. 2 mg oral ergotamine, 6 mg subcutaneous sumatriptan, 1 mg ergotamine with caffeine, 4 mg dihydroergotamine oral, 25 mg sumatriptan and butorphanol nasal spray. A 40-year-old woman presents with episodes of unilateral headache associated with ipsilateral meiosis, ptosis, rhinorrhea, conjunctival congestion and epiphora lasting for more than 2 hours. What is the drug of choice in this patient? So the symptoms here described are typical of a trigeminal neuralgia or a cluster headache. Why is it called cluster? What is a cluster about this? These headaches occur in clusters, like they will you get many episodes lasting for hours in a particular period of time and then they vanish. So that is why it's known as a cluster headache. It's a very disabling form of headache. Is also known as suicide headache because the headache is so severe that many patients consider committing suicide. So the drug of choice in this is indomethacin. Okay. So this is what are the features of cluster headache are: sweating of forehead on the ipsilateral side, drooping of eyelid, pain and redness, periorbital swelling, meiosis, epiphora and a runny nose. So that's all we have in Neuroophthalmology. If any questions or queries you have, please feel free to message me. Thank you. Let's move on to the next chapter in the next week.